So now I want to kind of take their stories and put them out here to the floor and open it up for questions for either of the speakers or even comments that sort of come to mind after hearing these stories. Yes.
Well, one comment. There's a foundation you should know about, the Mary Christie Foundation, and it was started by the parents of a student who committed suicide. And so the foundation, it's based in New York City, and their whole premise is to work with, they're working primarily with undergrads, but I think the case could be made to get funding for some work in graduate studies. And they've been holding meetings of college presidents and other groups. As the dean of the School of Public Health is involved. So I would just throw that out to the group as a resource, and because there is a funder taking this issue very seriously and trying to find, well, what are the best practices for prevention?
Thank you.
I was curious around how either of the stories, or maybe both the stories, in what ways might they, can you give us examples of it crystallizing into policy? Did any, either the verbiage that was used as a policy, or is a comportment of leadership or at the hospital or of other departments, is that almost like a model of policy? So either policy in words or policy in behaviors. I was interested in your distilling that out a bit more.
It's an interesting one because they're already policies, they're just ignored. And it's kind of weird that in healthcare, which is a caring profession, we should have a policy saying, don't make people feel terrible about themselves, don't be a bully, don't be a racist, don't be a homophobe. But there are policies. What we found was they were just ignored. And one of the things we've had to do is get a lot of them rewritten and updated to be far more pragmatic and kind of reminding people. So getting it on a lot of different colleges and our regulatory body's agenda, so that our regulatory body, the GMC, we got them 1 year to just ask about underreporting. And the GMC survey, so our regulatory body send a survey out to every resident in the United Kingdom. We have to fill it out, it's compulsory. And the rates of bullying were lower than ours. And we said, well, that's a bit of a surprise. We wonder why. And then it turned out that in the GMC survey, a bit like your glass walls, if you want to raise any concerns about bullying, undermining, or harassment, you give up your anonymity in the survey. And then those are released to your clinical supervisor and your program director, who potentially are the people bullying or undermining or harassing you. And if not, they're probably friends with. And so even that, we asked them to ask about underreporting. A lot of it is more about kind of opening that Pandora's box so that it suddenly becomes part of a dialogue and suddenly is on everyone's agenda. So there's not a meeting that happens now at the college at our regulatory body somewhere either our work or these issues at a professional level are not one of the bits on the meeting agenda, because it was always sort of kind of ignored and again, sort of it's what we always do, because we in healthcare have this wonderful nostalgic Stockholm syndrome where everyone kind of has drunk the Kool-Aid already. They've already bought into it. And we have a recruitment and retention problem. So speaking for trauma and orthopedics, and I'm not as old as I look, but back in my day when I applied for my residency, it was about 10, 13 to 1, the competition ratio. Competition ratio last year for trauma and orthopedics was 1.6 to 1. Plastic surgery is struggling to fill residency program places. Pediatrics are the same. We're struggling to get people to come to medical school. A number of medical schools last year had empty places. And those are that was one of those was a London medical school. And when we look into it, when we ask, like the vets say, it's culture. We're pushing to improve our diversity, both in terms of gender and race. You speak to sixth formers, so high school students, and they're already aware of culture. We have female medical students who go, I watch the way you speak to each other or behave, and I don't want to be part of that. So part of it is not just about changing policies, but actually making people take those policies seriously. I mean, even though it's kind of embarrassing, like I said, that we should have a policy that says, don't be racist, but it seems to be something that we need to have.
We were very fortunate through the survey that we could schedule a meeting with our accrediting body. The COCA is who accredits osteopathic medical schools to talk to them about some of the language. They have language requiring mental health resources on campuses. Their schools are required to have 24-hour access to care, but what we found was that wasn't specific enough wording. So, for example, a school, 24 hours access to care can just mean an online service that will schedule you an appointment for the next day if it's after hours. But if it's 2 o'clock in the morning and you go onto that online service, someone should be there to field that call, because a student in crisis is not going to say, oh, okay, I was going to kill myself, but now I'll wait till my appointment at 8 a.m. to go and talk to someone. So we had an opportunity to talk, and we're still working with them in order to finalize policy. We also reached out to our board of deans because we feel like that they could make more specific changes than maybe the COCA can, and talk to them about how important it would be for them to disseminate resources and have a best practices list. So we gathered all of the resources that all of the schools have. Now, can we put it together in a format, and will you share those resources with other schools, newer schools that are struggling? And they were very receptive to that, not necessarily as a formal policy, but as more of a spoken, we will share resources amongst each other for the sake of the students.
Kelly, can you speak to some of the other resources that are sort of being discussed as a standard expectation across schools?
Yes, absolutely. So the schools are, like I said, required to have the 24-hour access to care, but that can be online services. Schools that had the rated their culture the most positive had in-person counselors, and even more than that, would in-person psychologists and psychiatrists. One of the schools had a really, really neat program where they had a psychiatrist that worked for the school, but she was safeguarded from all of the students in that she saw them only as patients and had no influence over their grade or their evaluations. So she was not a clinical educator. She was a psychiatrist that worked for the school that had no impact on the students other than for their mental health. Schools have free fitness programs. We do have requirements to accommodate for different areas of wellness, like physical wellness. Students have to have access to physical wellness resources. Let's see. Schools have other things that aren't necessarily required. They have pet therapy. Some schools have. My school personally, we do like a food truck Wednesday, so we don't have a lot of food options on campus. And if you don't pack a lunch, then you're kind of stuck with, not to trash Subway, but it's kind of what you eat every day if you don't pack a lunch. And so just things like that our administration gets involved and trickles down. I wish I would have prepared.
No,
more.
that's fine.
I have a ton of resources.
Let's open the, yes. We'll start here and then Eric after that.
Thanks to both of you for sharing. I'm wondering, Simon, for you around feedback, giving and receiving feedback, that, when people demonstrate behaviors such as bullying and other things, I'm wondering what ideas you might have from within the organization, such as, it's almost like the patient safety things, the anonymously reporting things that happen because people aren't going to report on themselves. But if other colleagues, we open up surveys to all the health professionals who work with the residents and fellows, because we've had, communication type issues, so that there can be an anonymous feedback about, and, whether we could argue whether when you have anonymous, it's actually feedback, but it's providing more evidence that if there's a person that's behaving a certain way, typically more than one person will have interacted with them, and then that's where it should kick it up to somebody needs to sit down and have some serious feedback given.
It's a great question, because it's a double-edged sword. It's the law of unintended consequences. So what we've had is our educators, our faculty, our trainers saying, well, now I'm afraid to feed back to my students because I'm worried they're going to accuse me of bullying. And actually what we say to them is the same thing we would expect them of us, which is there's a way of feeding back to someone that it isn't bullying or undermining or harassment. It's feedback. And realistically, if you're a good person, you should want to know if you can be better. So the one of my most hated of phrases is you need to man up. There's normally an expletive in the middle there. And the difference is if you say in one of our, we have a trauma meeting in orthopedics every morning where the x-rays go up and you get quizzed, and then, now if I say, you know what, boss, I don't think I can do that case. I didn't read up on it, I'm sorry. Rather than telling me to man up, you can say, well, look, Simon, I'm going to be there, I'm going to support you, I think you can do this, but I'm not going to let you back away from this. I expect you to do this case and I'm going to support you. Same thing, different message. Similarly, what we want is to create a culture where actually accusations of bullying or harassment or any of those sort of things are accepted with open arms. So I was accused of bullying because I filled out a report about one of the more junior residents, and I said I had concerns for her. I said that I was really worried that she wasn't safe. And she turned around and said, well, actually, he's a bully. And this was fed back to me by my attending, and I said, well, that's great, because if you read my thing, I said, I'm worried that she doesn't accept feedback well, but maybe I am a bully. And my attending went, what? I said, I don't know, I might be. You've never watched me feed back to her or vice versa, so why don't we look into me and her, because maybe I need retraining, maybe she needs retraining, maybe we both need retraining, but let's go. And my attending went, look, I'm just going to tear up your letter and we're just going to tell her it's gone away. I'm like, no, seriously, maybe I'm a bully. And he was like, just never mind, it's fine. And that's the issue is there are different tools depending on what you're looking for. So it depends whether you want a screening test, which is a big survey. How is your unit doing? And then if you already know that there's a problem, and every unit often does kind of know, that one guy, that one girl, that one person, that one trainer, that one person, then in a way you're just looking for someone else to be brave enough to put their hand up. So again, whether you go for anonymous or not, whether you go for starting anonymous and then working your way down, whether you do really powerful things about having open circles, they talk about the kind of the cup of coffee concept, where you don't make it accusatory again, because accusatory gets people's backs up. You just say, can I have a chat with you over coffee? Nice public place. It's like breaking up with someone, right? You don't want them to make a scene, so you have them in the Starbucks. But actually it works really well. It's been shown to be really effective. And what you'll find is if they're, and this is personal belief here, if they're the kind of person you want to work with, they will go, mea culpa, oh my goodness, really? How can I be better? I didn't know. They might get a bit upset, that the standard, that training never did me any harm, et cetera, et cetera. And then eventually they go, well, right, there's a new paradigm, okay. But if you sit there and you go, well, actually, we've had this feedback and we've had this, and it says that maybe you could change the way you run this or run that or what have you, and their answer is, you're not the boss of me, it kind of tells you what you want to do. And we're seeing loads of little novel things. So, for example, we found that our trauma meeting every morning nationally was one of the places where a lot of these behaviors occurred, because it allows for loads of hierarchy, loads of a power differential. I'm big, you're small, I'm smart, you're dumb, there's nothing you can do about it. And one unit we found had a charter that they printed out, laminated, and put on the wall. This is what you can expect from us. This is what we can expect from you. If either side deviate, then we must call each other out on it. So that unit now is saying every now and then when one of the consultants, one of the attendings really starts to get het up with one of the guys, my level, about to go for their exam, and really, haven't you even read a book? I mean, you need to go back to medical school. The other attendings will go, calm down. Mr. Fleming, you know that you should have done better. We're going to ask you about this tomorrow. But even just having those charters, again, kind of really verbalizing those things, so it stops being this hidden curriculum, it stops being this unspoken rule, and actually you actively change culture. And again, it's about taking personal responsibility, which means, probably while I'll never be an attending ever again, residents have a responsibility too to go, sorry, boss, but you can't say that. Can't speak to someone like that. That's not okay. And it is a brave attending who allows that to happen, and a brave resident who says that. But again, if you create that culture, that's how it starts.
Great, thanks, Eric.
So Simon, I want to change gears a little bit. We've been talking about kind of the attending's behavior with regard to bullying stuff, but I wonder if you might reflect on the roles we ask trainees to play in the supervision they receive. And unfortunately, I'm chanting a little bit of what's been happening in the UK with the pediatrician trainee case, Babagawa. And I wonder if you might, and again, Callie, if you could reflect on, so sometimes we put you in pretty difficult positions that maybe that's not yet developmentally the right time for you to be doing that kind of stuff. And that causes its own set of stress that can then lead to some of these behaviors. I wonder if you both reflect on that kind of supervision question and what you've experienced both as a medical student, but as kind of an advanced trainee at this point. Where do we need to go kind of in that realm?
It's a culture thing again, isn't it? It's how competitive we are. We talk about, people get competitive about how burnout they are. It's interesting that as a trainee, certainly as a surgeon, you get to a certain point in your residency and you kick the boss out of theaters. I got this, boss. You'd have to come in. Don't worry about it. It's fine. I can cope, right? Don't be afraid to cope is a classic phrase. Don't be afraid to cope, Mr. Fleming, and then they disappear, right? And then you go on fellowship, and what do you want in fellowship? You want to be stood next to the boss all the time. And you suddenly realize that actually the best training is when you're being supervised and trained and advised and mentored and all that sort of stuff. And the Bawagaba case in the UK highlighted that. I don't know if everyone knows, a junior doctor recently.
Yeah.
So to all intents and purposes, there is a very busy, very famous pediatric unit, a junior doctor, a very senior junior doctor, so 1 year off finishing her pediatric residency, came back from a year of maternity leave, and on her first day was put onto their pediatric admissions unit, which had been shown previously to have a number of systemic issues about it. She was put on that unit. It was known to be understaffed. It was always understaffed, both doctor and nursing-wise. And there were other issues, like that day the computer system that reported blood results was failing, and so on. A very sick child came in. She was managing said child. She showed some results to her consultant, who basically said, "That's interesting, don't be afraid to cope." And he then left the hospital and said, "You got this." Other things happened. There was very much a Swiss cheese model that happened, including, for example, they had a paper system for recording where patients were and where they were moved to. So when this sick child eventually had an arrest, the junior doctor thought it was another child. There was a breakdown in communication, so the child who was hypotensive was given his regular antihypertensives by his mum, because his mum gives the medicines regularly, and no one had gone, no. So there was a catastrophe that happened that was heartbreaking for everyone. Unfortunately, there were then further things. So, for example, this doctor was told to go and have a chat with her consultant in the coffee room. They did a paper reflection in that coffee room. She said, "I don't agree with that. That's not what happened," and left. But that reflection ended up being utilized in the court case that eventually came up against her. There were a number of other issues. So, for example, she gave a report to the police, and she said, "Do I need to take anyone with me?" And they said, "No, you just need to go tell the police what happened. It's fine." She was like, "Okay, fine. No worries." So she was convicted of manslaughter by gross negligence, which is the highest conviction you can have without being convicted of murder in the United Kingdom. Then there was a lot of other stuff that happened, but it ended with our regulatory body taking away her license to practice, even though, and so there are a number of issues that come out of that around reflective practice and around supervision. The issue is a culture of being able to speak up. There's other cultures, like, does your attending really have your back? Really? Because we always believed they did, and now we're not so sure. There's the culture of whether or not we should reflect, and if so, how? Because suddenly we're all terrified that they're going to be used in a court case against us. But in terms of the supervision thing, it is creating a culture whereby if we feel we are working in an environment that we can't be, shouldn't be, mustn't be, number one, not only do we speak up, but again, it's not about us. It's also the culture of our attendings and our seniors and our colleagues going, "I've got your back," and helping us out. So the NHS is chronically understaffed, famously understaffed. And we're still looking for answers about what do you do if you turn up and you're... So we have registrars, and then we have SHOs, one up from an attending, not quite a resident. What do you do if you don't have a resident, a junior resident? Now, there are hospitals now where what's happening is the attendings are coming in and doing the registrar job. They're having to come in onto the shop floor and do the registrar job, because actually otherwise the safest thing to do is to go home. And we're still trying to work that out, because again, it requires a culture shift, because the culture shift was always don't be afraid to cope. It's why, and I've tweeted about this, and mea culpa if you're the victim of it, it's why I hate the word resilience, because resilience implies being able to cope with a difficulty. But we're being told to be resilient in the face with an ongoing, relentless, never-ending difficulty. That's not resilience. That's just accepting that everything's awful. So it's not about, it's about changing a culture whereby you actually have to say, as an attending, as a resident, this isn't okay anymore. this isn't okay for me, this isn't okay for my patients. And part of that is around, I need you in theatres today, boss. But you can do this case. I know. But I'd like you to be in the hospital because this patient is an ASA4, or because I've just come back from maternity leave and I just think you should just be in walking distance, or whatever it is. And again, it's a brave resident who says that because it is perceived as weakness. And it's a brave attending who, if their resident doesn't say that, says, I'll be around, and doesn't make their resident feel like they think they're weak. Because that's the other thing is, oh my God, my boss doesn't trust me, right? In trustability, I trust you to do this operating list, but I also know you've been away for a year. So you know what? I'm not going to come in and bother you, but I'll be in my office and I've got my mobile on. You've got this. I've got trust in you. I know you're good. And again, it's a whole culture change of openly verbalizing, okay, this is the state we're in, this is how we're going to deal with it, rather than that unspoken, I expect you to cope, or else.
Kelly, do you have any thoughts about supervision or?
I guess as a medical student, our culture is, if you want to be, the best you can be on a rotation, is to never say no. So if someone offers you an opportunity, do you want to suture this? Do you want to intubate? Do you want to do this? Is yes, of course I do. And so blindly, a lot of the times we will say yes to be impressive. And we work most closely with residents, and I think the residents are pretty good about saying, have you ever done it before? Because we will immediately say, yes, I'll do it. But I've never done it before. So mostly the best experience I have is with a resident that will say, okay, well, I'm going to stand right next to you, and we're going to talk through the whole thing, but you're going to do it. On my emergency rotation, I was offered the opportunity to intubate a patient. He said, I'm going to stand right next to you, and you can try twice. And then I'm going to take over. My hands are right here. You're not going to fail. This patient is going to have an airway, but you're going to have an opportunity to do this on your own. So that was probably, as far as supervision as a medical student, we want to seem competent and we want to be impressive. But I think recognizing that communication is key, and we will be ready to please and show off all of our abilities almost to a fault sometimes.
I would add to that, it's that verbalization. So something that I'm far enough along in my training that I often will be doing the WHO checklist, in the operating the WHO checklist. And even then, you can verbalize those things. So I think verbalization, saying, I'm going to do this bit, and then you're going to do that bit, and if this happens, I'm going to do this, and I'll take away that, and don't worry, I'll be... Even that is a change from that assumption of, Simon's going to do this case. Well, what happens if Simon can't do this case, or needs help, or, so when I do the WHO, I'll say, I'm doing this, Dr. So-and-so, Mr. So-and-so is in his office. If I ask for help, that's where he is. If I can't get this is all very orthopedic, but if I can't get the guide wire in within half an hour to 45 minutes, can someone let me know? Because I've gone tunnel vision and I need a hand. And even those sort of verbalizations, or just saying, if I'm at 45 minutes and haven't gotten to this stage, don't be afraid to get Mr. So-and-so in to... If you verbalize those things, then supervision again doesn't become that thing of, oh, you can't cope, you're not good enough. That's why I'm a trainee. I'm still learning.
Can I respond to that?
Yeah.
I'm struck though by the ad hocness or variability of the system, that it's dependent on who you get as a resident, the culture that's been set up, who has enough insight in, and I'm just reflecting on things that happen here as well, is that type of system is not terribly patient-centered. And I think that's something I think is important for us to bring back into this, is that we've designed educational systems that often look at us first and too often the patient's an object, right? Instead of a subject. And so I'm struck by your stories, as I hear in many other places, that variability could not necessarily be a good thing for the patient.
I think we're all guilty often of forgetting about the patient. I know I often am, because when I'm worried about my training, I'm often worried about me. And it was interesting that one of the early talks this morning where they talked about to support doctors with burnout, they introduced loads of more support so they didn't have to come to the emergency department, and more resources so that not all well, that to me just sounds like better patient care, but actually that was a resident-centered anti-burnout thing, but actually it just sounds like having better resources for taking care of patients. So we worked very closely with patient liaison groups with our campaign, and the stuff we got out of them, before we got to the patient safety stuff was I remember vividly, she said, we can hear you, right? And I was like, what? And she was like, when you talk to each other, we're sat right there. When, on rounds or in clinic, when someone, when you're being told off or spoken, we all hear you and we're there too. And you're like, oh God, yeah, no, so even before you lay hands on them, they're already like, the people who are taking care of me are mean. They're mean people. Because then, of course, you turn and you've got your empathic face on, and you're like, how are you today? But you've just told some intern that they need to go back to medical school and learn how to put a cannula in. Anyway, how are you doing today? Like, they see that too, and that's long before you do anything doctory. But yeah, bringing it back to patients, because there's a huge amount of variability in supervision, and it's the same when you're a resident. The ability to say no or just ask for help, and getting the response you need from your attending, which is not always yes. It's not always yes, but it's about how you say no rather than man up or don't be afraid to cope or I taught you this last week. Well, yeah, okay. Well, I've forgotten. I'm really sorry.
Yeah.
Hi, Eric Sid from the NIH. So I liked this question earlier about patient safety. I think it's an interesting juxtaposition because I feel like, in patient safety, you have sentinel events, so serious adverse events. Nobody would imagine, not talking to the families or the patients that are impacted by that. But, when we have these discussions about physician or, provider wellness and burnout, who are we not having in these conversations? Do we not have our own serious adverse event? Either evaluation metrics, and those folks that end up dropping out or burning out or not being able to progress in their careers, they're not on this panel. They're not part of this discussion. We don't have survey data on those that drop off. I find it interesting because, so I personally burnt out from medical school. I completed, but I haven't gone on to residency. Maybe I will go back, but I felt incredibly just taxed during the process of just personal issues. Talking about this variability again, that, oftentimes you have these Swiss cheese models that maybe all the things will line up and everything, all the support is there, and maybe not. My diversity director, who was the person that recruited me, happened to leave right on, after I had personal family issues coming up. And, oftentimes, like Callie was saying earlier, and thank you again for coming here as a medical student, but, medical students always want to say yes to everything, not necessarily to be impressive, but, for example, my school recruited me to the school because of my work in diversity and outreach and trying to increase the pipeline. So when my class didn't have, only had one African-American student in my entire cohort, then I took it upon myself to go out and do lots of outreach. And why are we spending as students all this time organizing conferences and writing down, doing meetings and planning events because we don't have the funding for a staff person for our office to do that? There's competing needs and there's competing demands for medical students. I have a number of different friends that during their time in medical school, they were using their financial aid to support family members because, your life doesn't end when you go to school. And again, it's my dilemma with this whole situation is when we talk about, again, patient safety, it took us a long time for the field as a whole to develop this culture of openness. Why aren't we using those same lessons that we've learned around patient safety in this discussion about wellness?
It's interesting you mentioned that. So there's an organization in the United Kingdom called the Academy of Medical Royal Colleges. So the UK has more royal colleges than it can shake a stick at. And there's an organization where every president of every royal college sits on, called the Academy of Medical Royal Colleges. I'm the vice chair of the trainee arm of that. We have something called patient never events in the UK. I don't know if you have the same thing in the States, right? Never events. You shouldn't leave a swab in someone or your wristwatch or whatever. And have developed something called training never events. So a training never event should be, for example, is a suicide. And a training near miss would be a parasuicide or suicidal ideation or what have you. As in, no one should get to that point. Training never events, right? Training never event should be a trainee doing a procedure that they cannot do. A training near miss is getting to the point where they're like, please, someone help me. I'm going to do the thing that I've... And we're doing exactly that because we realize that actually by doing that stuff, it's still patient-centered. It's just looking at it from another angle. Because if I'm about to do something in my training that should never happen, by definition, chances are there's a patient at the end of it.
Yes. Oh, I'll come over here next.
It's a work in progress. The check's in the mail.
Go ahead. Table 6.
Hi, Bob Piccinini with the American Osteopathic Association. Actually, Callie's being very, very humble. Her group has caused us to have, with the Osteopathic Association, a strategic front on dealing with this. We've taken a cradle-to-grave approach and set up policies. We're the overreaching arm. And in the AOA, it's easy because we're more of a pyramid situation as opposed to like with ACGME where it's a confederation of specialties. Basically, we say what needs to be done and it's done. So we're taking this, a couple of the initiatives that we're doing differently is looking at our culture and forcing what we're, not forcing is maybe not the greatest word, but developing a train-to-trainer program, because by virtue of our degrees doesn't make us the greatest educators. So we need to go back and teach our educators how to be more effective with our students. And then the other thing that was unique to our holistic approach was that we're actually engaging the families of our students, not just the students, but the attendings, the residents, basically the pre-students, because they're often the canaries in the coal mine, and they can see things happening in their families ahead of time, and we're trying to make things available to them both for themselves and for them to have an avenue to speak up for their loved one or a partner who is maybe struggling but doesn't want their attendings to know, doesn't want, so we're providing other resources and other avenues so that we can step in and try to help these people succeed. So, thank you,
That's
Callie.
great. Thank you. Table 7.
Callie, thank you very much for sharing the story that you did about that 2 a.m. phone call. I wanted to reflect a little bit at my college a few years ago. We had a student go through a very, very significant mental health issue, and we were able to assist that student in appropriate intervention, wound up in a hospitalization, and got the appropriate care that was needed. But the event was so significant that we started asking and saying somebody had to have known that something was going on. And we went back to all the faculty members and we went back to classmates, et cetera. And what we discovered was this had been going on for quite a while. And the individual student had a whole network of classmates who was supporting her, who were, assisting her in ways. And when we reflected upon it, it seemed to us that it actually prevented her from getting the care that she needed in a timely fashion. So what advice do you have about trying to create a culture where if a student knows something, that they also know that they can share that maybe beyond themselves? Because I think the point was very eloquently made that when you're a student and you're engaged in your own learning and your own self-care and you're a leader and you're doing all these things, that's too much. That's just too much. And there's a safety net available for you. So how can we assist with some of those aspects?
Thank you. I'm really sorry that that happened on your campus. I hope that she's doing much better now. I think that through our survey, one of the questions that we asked was, is there a designated faculty champion on your campus? Is there one person that you would know to contact at your school if you were having these issues? And across the board, some students put their own name as the champion of wellness at their school. And like you said, that can't fall on students. It just can't. And so I think it's really important that it's a well-designated person on your campus. And safe reporting avenues are key. I know we had an experience on our campus where a student of color, a very good friend of mine, was in an incredibly uncomfortable situation where a trainee was extraordinarily racist to her. And when she came back to the campus, we realized she didn't have a safe avenue to report that to anyone. And so we made it something that we absolutely needed on our campus. And we went to our administration and they were floored. They had never seen anything like that before. So they immediately instituted this safe avenue for reporting things that happened. So I think that, letting students know, one, you have a safe avenue, two, there's a specific person and here's all of their information and you can get a hold of them whenever you need to. And lastly, something really neat that a lot of our schools have started doing is QPR training. It's question, persuade, refer. So if someone, and you train your students, it costs like $200 to get the training on your campus. And so all of your students can become QPR certified. And so if someone comes to them and says, I want to commit suicide, they have the tools that they need to say, why do you want to do that? Can I talk you out of it? Here's where we can go and get help. So just kind of providing those resources for your students.
Great. And Lizzie, I think, next.
Thank you both very much for those excellent, really inspiring stories. Just wanted to ask, make one point really and then ask a question. So the point really, and I think it comes back to the bullying thing, is that one of the things that I think we all don't get taught or don't see role models around is how to disagree without being disagreeable. So things, when you want to call somebody on something or you see something that's not working, because we don't have the tools to do that, it suddenly gets escalated into this aggressive conversation. And partly I think that comes back to being a professional and everybody in the room being trained to be the one who's always right. And if you get too many people in the room who are trained to be the one that's always right, then there's going to be a fight, right? So if people get the skills and early training on how to have a conversation about something they don't agree on without escalating that to being disagreeable, I think that can be quite helpful. The question I wanted to ask, though, and I'm not sure if this is relevant to you or not, but one of the things we see in the veterinary profession is not just bullying within the veterinary team, so between nurses and veterinary surgeons and support staff, but from the clients to the veterinary surgeons to the veterinary nurses. And there was a survey recently in the UK veterinary profession, I can't remember the figure, but quite a high percentage of veterinary surgeons said they had felt bullied by their clients. Now, in this situation, I guess it's often patients, but is that a thing in the medical profession? And if so, how does that work alongside the kind of anti-bullying campaigns that you have running?
Again, within the UK, it certainly does happen, not as commonly. What we do see, for example, and I'm sure it is prevalent in the US, is bullying from people within the hospital community who are not necessarily medical. So I've had a lot of consultants say, my management bully me. Who do I go to? My line manager, my chief executive, my whoever are bullying me. Who do I go to? But patients, we do again, give me what I want or I'll complain sort of thing, or I'm going to, and again, part of it is about having the skills to deal with that. So I can actually talk about it now because the interviews have happened, but one of the communication stations for orthopedic selection this year that I helped write was about that, where a patient comes in with a clavicle fracture and says, I want an operation. And the doctor said, the trainee is asked to say no. And they push and push and push, and they threaten to complain, and they threaten to call in this. And it's about how they manage a person. Basically, you trying to use their power as I can complain, I can call your senior, and how you de-escalate that and manage that. And it's kind of conflict resolution and so on and so forth. And it has a huge part to play. But again, it's about how we as a culture behave. Because actually, if they come in and they already know that there's a hierarchy and there's that kind of passive-aggressive thing going on, and we're kind of already starting with that. So, for example, I introduce myself as Simon, and I don't call myself an orthopedic surgeon. I say I'm one of the bone doctors. You set a tone of, I'm here to help you, is very different to, hello, my name's Professor Fleming. I'm one of the orthopedic surgeons, and with all due respect, I know. And, if you create an environment whereby those behaviors are already sort of abnormal, then they're the abnormal behavior. If you create a culture where everyone's ready for a fight, the patients... I'm a patient, so I can say this. Patients are like, dogs or sharks. They can smell fear. So if they sense that atmosphere already exists in the room, they're going to feel okay with going, look, I'm going to complain if you don't give me what I want. Whereas if you're already patient-centered, really those behaviors are then easier to call out because you can go, well, you're behaving unreasonably because I've done nothing but try and manage your ideas, concerns, and expectations.
I'd like to speak to, I feel passionately about this. We have real safety risk for our providers in many of our healthcare settings in the United States in particular. We do a full simulation de-escalation training for 100 new interns every summer, and I sit and say, oh my God, am I a horrible DIO because I'm having them go through this training with an amazing actor that scares the bejesus out of them. My fourth grader gets active shooter training every year in a public school where they hide in a closet and are told, wait for the badge from the police officer before you open the door. I mean, shame on us as a healthcare system to not be preparing and empowering our employees also to recognize bullying from patients in a culture that's actively shifting. So I will call out to Eric in the ACGME. I am a site surveyor for the CLEAR program, which is the Clinical and Learning Environment Review program. And then I'm astonished that we aren't talking to residents and faculty and nurses about whether they feel safe at work. I think that is a huge area that if we're going to bring a capital P to policy, that we start to say, how are we also paying attention to the areas of vulnerability that keep us safe as healthcare providers? So that leaves us, 2 minutes. And we didn't really talk about policy, except to say, I think the big piece is the capital P policy often plays a beautiful role when you have a yes or no question, when you have a discrete line in the sand that you can draw to say this is allowed and this is not. But the world that we live in is one of polarity. And the polarities are, yes, we need standardization, but you know what? Sometimes customization is critical. Yes, we need to have autonomy, but we also really need collaboration. And that is a constant negotiation. It's Simon's comment that, those policies have existed for 25 years. The problem is we haven't embraced it as a culture. So thinking about that, thinking about policy, and oftentimes we focus on that as the work, when in fact that's the technical fix to a much bigger adaptive problem that we are facing. And you have all enlightened with really interesting stories and some solutions that I plan to poach and steal and take home. And I'd really love to thank both of our speakers who traveled far and wide to be here today.